Good morning everyone. Myself Dr. Alka Hande. I am working as Associate Professor in the Department of Oral Pathology and Microbiology, Sharad Pawar Dental College. Since last 22 years I am working in this institution. Fine. Now let's come to the today's topic of discussion. You all are aware that since last about 3 to 4 classes we were discussing about the odontogenic lesions, and odontogenic lesions comprises of odontogenic cysts, tumors and certain non-odontogenic lesions also. In last class we had discussed in detail about the classification of the odontogenic tumors. Now from today onwards we are going to discuss about the odontogenic tumors in detail. In the classification you all are aware that basically they have categorized into 3 categories, as the odontogenic apparatus comprises of 2 important epithelial tissues. One is the odontogenic epithelium and another is the odontogenic ectomesenchyme. So the classification basically categorized into 3 odontogenic. First is the odontogenic epithelium with mature connective tissue stroma and without odontogenic ectomesenchyme. In this first category, the first tumor is the ameloblastoma. So now you are going to discuss about the ameloblastoma. So what are my today's learning objectives? At the end of the lecture, students should be able to understand the epidemiology, etiology, clinical features, radiographical features and histopathological features of ameloblastoma. Now to introduce to the ameloblastoma, odontogenic tumors are lesions which are derived from epithelial, ectomesenchymal and or mesenchymal elements that are or have been a part of tooth forming apparatus. What is the second criteria or characteristics of these odontogenic tumors? They are exclusively found in the jaw bones. That means they are intrabony or centrally located, or in the soft tissues overlying the tooth bearing areas. That means they are peripheral. So in short we can say that they are categorized into 2. One is intrabony, second is the extrabony or the peripheral. Now let's discuss about the details about the ameloblastoma. Now in short about the history, this ameloblastoma first time reported by Cusack in 1827. Further in 1868 Broca described it in detail. Then in 1879 Falkson given the description of this tumor. Further in 1885 Malasses named it as epithelioma adamantine. Why it is given as the name epithelioma adamantine? Because it could arise from debris epithelials. And in 1930 Churchill named it as ameloblastoma. So the definition, by definition Robinson first defined it as a tumor that is usually unicentric, non-functional, intermittent in growth, anatomically benign and clinically persistent. So the pathophysiology of this ameloblastoma itself is explained well in this definition. Usually unicentric. What do you mean by unicentric? It starts or it begins with the single centric lesion. It is non-functional. Why it is non-functional? We all are aware that it is derived from or developed from the odontogenic epithelium. Now odontogenic epithelium, actually its function is to form the or to develop the tooth. So when it is called as non-functional, after the function of the odontogenesis or after the function of the tooth germ formation is over, when it is called as the non-functional. It is intermittent in growth. Intermittent in growth means it is not continuous, it is very slow growth, anatomically benign and clinically persistent. Now the ameloblastoma, that's why it is considered as a true neoplasm of odontogenic epithelial origin. It is considered as a second most common odontogenic neoplasm. Which is the first one then? Yes, you all are aware that the odontome is the first most common odontogenic neoplasm. Now the ameloblastoma may occur centrally within the bone or peripherally without an intraosseous component in the soft tissues. That we had seen or we had discussed in the beginning only, that there are 2 variants, one is central and another is the peripheral. Intraosseous lesions outnumber the peripheral lesions by at least 9:1 margin. That means if the 10 cases are there reported, 9 cases you can see intraosseously or centrally, whereas only 1 is peripherally. Now let's discuss something about the epidemiological data. Now if you consider the age range, it can occur over a broad age range. Average age as diagnosis is third decade, third to fourth, rather grossly you can say 33 to 39 years of age. Then only about 10% of the cases are reported to arise in children, and less than 1/3 of these cases occurs younger than the 10 years. In short, we can say that it is a tumor of the middle age. If we consider the gender, or if we discuss about the sex predilection, there is as such no significant sex predilection has been reported. That means it can be seen in males as well as females. Then if we consider the racial preponderance, there is increased incidence of ameloblastoma is seen in the black individuals as compared to the other racial groups. Now what is the histopathogenesis, or what is the histogenesis of tumor? So it is said that various researchers have put forth the origin of the tissue or origin of the ameloblastoma. Though it is said that the exact origin is not known, but there are certain factors which can be from which the ameloblastoma is derived. What is first? It is the disturbances of the developing enamel organ. We all are aware that enamel organ comprises of odontogenic epithelium as well as odontogenic epithelial tissue. And when it goes to the various stages of the tooth development, say bud stage, cap stage, bell stage, advanced bell stage, and finally it reaches to its destination, whatever is the required or destined tooth to be formed. Whether there are any genetic changes, whether there are any environmental changes, whether there are any metabolic disturbances, because of one or the other reason, if disturbances occurs, then that may lead to the tumor-like lesions like the ameloblastoma. Second, cell rest of series. What are cell rest of series? We all have studied in the first videos that after what is the function of the dental lamina? Now dental lamina is the extension of the oral ectoderm. When it extends into the underlying ectomesenchyme, it goes to the various stages of the tooth development and ultimately it forms the tooth. After the function of the dental lamina is over, its cell rest remains in the oral epithelium connective tissue and they are called as the cell rest of series. Second, cell rest of molasses. What is cell rest of molasses? Yes? Yes, very good. So cell rest of molasses are the rest of Hertwig's epithelial root sheath and they are found reminiscent or they are found inactive in the periodontal ligament. Now next, tissue of origin. Sometimes basal cells of the surface epithelium of the jaws. We all are aware that basal cells of the surface epithelium has the ability to undergo mitosis. Next, epithelial lining of the odontogenic cyst and particularly the dentigerous cyst and odontome. Now when we had discussed about the odontogenic cyst, you all are aware that the epithelial lining of odontogenic cyst, it has the tendency to transform into a neoplastic proliferation and particularly the dentigerous cyst. And last, tissue of origin, heterotopic epithelium in other parts of the body, especially the pituitary gland. So these are the different cells from which the ameloblastoma can arise. Now next, the site of occurrence. What are the different areas in the oral cavity which are more prevalent? So mandible. Now as you all know that this is an intrabony lesion. So either it may occur in the mandible or the maxilla. So amongst these two jaws, mandible is the most commonly affected area where more than 80% of the cases occurring in the mandible. That too mandible in which area? Whether anterior or posterior? No anterior. The posterior area, that is a molar, angle or ramus area, is involved 3 times more commonly than are the premolar and anterior regions. Then if it is there in the maxilla, then maxillary anterior and posterior more or less same prevalence is there. Then it is said that the maxillary tumors tend to occur in slightly older patient than do the mandibular. Now let's see how the patient presents with the clinical signs and symptoms. Now you can appreciate in this clinical picture that this is about 30 to 35 years male patient where he has presented with this large swelling which is involving the right side of the mandible, which is extended up to some portion of the maxilla also. This is an extraoral presentation. Here you can appreciate, this is a picture from the another patient where you can see that there is some small swelling in the left side of the palate where it is involved the little bit of the alveolar ridge. So Clinically, how does it present? It's slow growing with few or no signs in the early stages. As it is discussed or as it is mentioned in the definition that it is very persistent to growth. It is very persistent in growth, so that's why it is very slow growing. Most commonly present with the chief complaints of swelling and facial asymmetry, which can be very well appreciated here. The patient presented with the swelling and facial asymmetry. Most of the time the swelling is asymptomatic and sometimes the pain is an occasional presenting sign. Next, now the continued growth of the tumor and enlargement of the involved area may eventuate in ulceration of the mucosa. As it can be very well appreciated here, the tumor is showing the bony enlargement in the anterior region of the mandible, where you can see that slight ulceration, surface ulceration. You can very well appreciate this redness of the inflamed area. So if the tumor is large enough, then sometimes it may explode, or it may come to the surface, and there you can very well appreciate the surface ulcerations. Then small lesions tend to be discovered more often on routine radiographic screening examination. As we have seen that these lesions, most of the time they remains asymptomatic. So if the lesions are very small, then patient may not notice it. If the lesions or the swelling is very small, the patient may not notice. The patient may have come for the another reason for the screening examination, and then we come to know that the diagnostic features that there may be through the routine radiographic screening examination. Now if there is a large bony swelling is there, what are the local effects of this? There may be tooth mobility. Obviously there is an expansile bone lesion is there, then the adjacent teeth may show mobility. There may be because of the mobility of the teeth, the occlusal alterations may be there, and sometimes because of this large bony swelling there may be the failure of eruption of the teeth. Now this intrabony swelling, how does it radiographically present? Now here you can very well appreciate that the lesion is there in the posterior region of the maxilla. And what is its radiographic presentation? You can very well appreciate it is a multilocular radiolucency. This is one locule, second locule, another locule, and all these locules are separated by this radio-opaque septate. So radiographically, this intraosseous ameloblastoma, its classical presentation is multilocular or soap bubble radiolucency. Can you appreciate this soap bubble of radiolucency or the multilocular? Rather you can say it is a characteristics radiographic description of the ameloblastoma. Not only the soap bubble or the multilocular radiolucency, it presents with the other radiographic patterns, like sometimes it may be unilocular also. When it is unilocular, the border is usually smooth. So, and unilocular lucency with a scallop or the lobulated border. Sometimes a poorly delineated mixed lucent opaque lesion may also be there. As it is an intraosseous lesion, so most of the time it is unilocular, sometimes multilocular, and mostly it presents with the soap bubble or the honeycomb like presentation. Now here you can appreciate that there is a single large unilocular radiolucency in the mandibular posterior region. So when the unilocular lesions are associated with an impact tooth, here you can very well appreciate that this is a deciduous tooth, and this first molar, because of this radiolucency, it has shifted to the lower border of the mandible, and this developing second molar has shifted towards the ramus region. So what will be your radiographic differential diagnosis in this case? If such type of radiographic presentation is there, yes, definitely it will mimic like that of the dentigerous cyst type of relationship. So if the lesion typically is found surrounding the crown of the impacted tooth, then the differential diagnosis will be of your dentigerous cyst. Though the differential diagnosis clinically is dentigerous cyst, but histopathologically will confirm the diagnosis. Now here you can appreciate that in this mandibular third molar area, it is the most commonly involved area. This is a resected mandible. Here you can appreciate this multilocular radiolucency. Here you can appreciate this soap bubble appearance. Now impacted teeth, the prevalence you can say only 15 to 40% of the cases shows presence of the impacted teeth. Now the macroscopic appearance, as it is a benign tumor, so surgically it is removed. And how does that clinically manifest? There is a cylindrical or fusiform swelling showing the expansion of the bone. Sometimes there may be the perforation of the cortex. Then how is the lesional or the neoplastic mass? Mostly it presents with the greyish white or greyish yellow color. Then it is readily cut, containing no calcification. This itself explains that it is a true epithelial tumor without any calcifications. Some cases solid and in some cases cystic spaces may be present. We have seen in the radiographic presentation that there was a multilocular radiolucency. So sometimes when we can see the macroscopic appearance of this lesion, there may be the solid as well as the cystic. And just remember this point, some cases solid and in some cases cystic. This has to be correlated with the histopathological presentation, which I am going to show you later. Then suppose there is a cystic spaces is there, some content has to be there. So there is a straw colored fluid or semi-solid material may be present in the cystic component. Then if it is related with the impacted teeth, then sometimes there may be the multiple teeth present. Now the most important is the histopathological features. Now histopathology, we all know that this tumor is subject to the histopathological examination. Now basically the histopathology, two main patterns of ameloblastoma are recognized. One is the follicular and second is the plexiform. The names, the follicular and the plexiform, they are named according to its histopathological presentation. Not only the follicular and plexiforms are important, there are other histological subtypes also. Now let's see which are they. First is the acanthomatous, then it may be present as a granular cell, basal cell, desmoplastic, clear cell, keratoameloblastoma, papilliferous ameloblastoma and sometimes hemangiomatous ameloblastoma. So the basic or the main patterns are follicular and plexiform, whereas other histological patterns acanthomatous, granular cell, basal cell, desmoplastic and so on. Yes, you can say the mucous cell differentiation also. Now let's discuss about what is its prognostic implication. There are basically two types, follicular and plexiform. But what is its important? Why do we differentiate them, whether they are follicular or whether they are plexiform? So that has the prognostic implication. It is said that, or the researchers review that the follicular type of ameloblastoma had the highest rate of recurrence, say about 29.5%, little less shown with the plexiform type of subtypes, only 16.7%, whereas the acanthomatous, it recurs very rarely, say 4.5% of the recurrence rate. Whereas other variants, say granular cell, basal cell and desmoplastic subtypes, the recurrence rate is documented but it is very, very minimal. Now the typical histopathological features of this ameloblastoma. So in 1970, there was these two researchers or persons, Vickers and Wardha. They created, or what you can say, they described certain classic features. So when you diagnose histopathologically this tumor as ameloblastoma, this must fulfill this Vickers and Wardha's criteria. Now in this picture, does it give very similar to, do you remember something by looking at this? How does it giving the similar resemblance to what structure? Yes, it is similar to the advanced base stage enamel organ, where you can very well appreciate this tall columnar cells with hyperchromatic and oval nuclei, and here this tissue resembles to what? Yes, it resembles to that of the stellate reticulum-like cells. So what are the Vickers and Wardha's criteria? There is a darkly staining periphery composed of tall columnar cells. Now you just look at this histopathological picture, you can very well appreciate that here there are darkly staining peripherally cells which are tall columnar. Hyperchromatic nuclei, yes, you can very well appreciate the hyperchromatism of this nuclei. Then third criteria or third feature of this Vickers and Wardha is that a small clear vacuole between the nucleus and the basement membrane. Now here, look at here, you can very well appreciate this is a tall columnar cell, hyperchromatic nuclei, this is a basement membrane. So between the nucleus and the basement membrane, you can very well appreciate this clear vacuole. So these three criteria, first tall columnar cells, all the nuclei at one place, it is called as the palisaded arrangement or the tombstone arrangement. The nuclei are hyperchromatic and it is called as the subnuclear vacuole or the clear vacuole between the basement membrane and the nucleus. Then, specific about that, it mimics the normal embryologic development of tooth bird at the stage of enamel matrix production. Now let's discuss or let's see about the or let's study detail about the histopathology of the follicular ameloblastoma. It is amongst the various variants, it is considered as a most commonly encountered variant, and all the core features of ameloblastoma, they are very typically present. Now as its name suggests, follicular, what do you mean by follicular? The histopathologically it presents in the island. See here the follicular ameloblastoma, it primarily tends to grow in islands. Sometimes there are presence of cords and strands are also seen. But as it is primarily or principally grow in islands, so that's why the name follicular ameloblastoma. Then the islands of tumor in the follicular ameloblastoma, sometimes they can enlarge to such a great size that there may be central cystic degeneration is there. So first, histopathological presentation, their growth in the island form, and then if the islands have grown large sufficient size, then there may be the central cystic degeneration. Now this you can very well appreciate in this histopathological picture. Now look at here, this is one odontogenic island, this is another island. So this follicular ameloblastoma, rather you can say, this grows in typical, this one follicle, another follicle. Here also you can appreciate this follicle and all these follicle, the spherical island, so where you can see follicles. Now here you can see that each of this follicle is lined by these tall columnar hyperchromatic cells with subnuclear vacuolization fulfilling the criteria of the Vickers and Wardha. Now see here, there is a large follicle here. So because of the large size follicle, the central area shows cystic degeneration. Then, how are the central cells? The follicle, when we are seeing, it is lined peripherally by the tall columnar cells, whereas the central cells are typically polyhedral to spindle shape. How is their shape? They are polyhedral to spindle shape. When spindle shape, they often have the angular nuclei and very poorly defined cytoplasm with delicate fibrillar cytoplasmic processes that contact with the adjacent cell. And such type of presentation, polyhedral to spindle shape cells with long anastomosing processes, so it simulates to that of the stellate reticulum like cells which we have seen in the developing enamel organ. Here again the same picture, here you can very well appreciate each of the follicle lined by tall columnar cells, and central area shows presence of stellate shape or polyhedral cells with long anastomosing processes which simulates to that of the stellate reticulum. Here is another picture, the similar presentation. So in the follicular ameloblastoma we have seen grossly it presents with the two characteristics. Each of the follicle is lined by the, so in the follicular ameloblastoma each of the follicle is peripherally lined by the tall columnar cells which remind us of that of the ameloblastoma like cells. Tall columnar cells, hyperchromatic oval shaped nuclei, and there is a presence of subnuclear vacuolization which fulfills the criteria of Vickers and Wardha. And when the follicle is large enough, it shows central cystic degeneration sometimes, and each of the follicle centrally there are presence of the long anastomosing joint spindle shaped cells which simulates to that of the stellate reticulum. So these are the particular characteristics features, histopathological characteristic features of the follicular ameloblastoma. Now considering this as a key features, now we will discuss how the other variants differentiates from this follicular ameloblastoma. So let's see about the acanthomatous ameloblastoma. It may closely resembles to that of the follicular ameloblastoma because it grows in an island-like pattern. Then it differs from the follicular ameloblastoma in the nature of the central cells within the tumor islands. So it is there, the pattern is that of the islands or follicle, only difference is in the central cells. In the acanthomatous ameloblastoma there is a squamous cell differentiation or squamous cells replace the stellate reticulum like cells. When you know that the keratin, what are the different types of the keratin? It is the orthokeratin as well as the parakeratin. So here mainly there is a parakeratin, and this effect produces a distinctive pink color change compared with the deeply basophilic staining which is maintained in the peripheral columnar cells. Sometimes there is in the central portion there is a squamous differentiation, a layer of stellate reticulum like cells are there which separates the peripheral columnar cells from the central squamous cell. If the islands are large enough, you can appreciate the central cystic changes. Now look at this picture. See here, these are the various islands or follicles. Here also you can appreciate in this third one, here also. Now here centrally you can see these are the stellate reticulum like cells. Fine. And the central portion here, the central stellate reticulum like cells shows squamous metaplasia or squamous differentiation. You can very well appreciate these keratin filled cells appearing like the keratin pearls, and periphery to this squamous metaplasia a bit amount of the stellate reticulum like cells is there. So in acanthomatous ameloblastoma it is similar to that of the follicular ameloblastoma. The only difference was there in the differentiation of the central cells. Now let's discuss about the third variant or third histopathological pattern, that is a granular cell. Now characteristic feature is the presence of granular cells in the central portion of the epithelial islands, strands and cords. Now these granular cells tend to be large and they have an oval to polyhedral outline. Because of this granularity or because of the cells, large polyhedral cells filled with the granules, the nucleus is displayed to the periphery of the cells. And these prominent coarse granules pack and distend the cytoplasm, which impart the distinctive appearance responsible for the name of these cells. This is considered as a, or this is called as a granular cell ameloblastoma. Why granular cell? Because these polyhedral cells are packed with the prominent coarse granules. Now sometimes these granular cells show sharply delineated cell border, but most often the cell membranes are very poorly demarcated. Then how is the color of these granules? The cytoplasmic granules, they stay weakly eosinophilic, and around to that, like the acanthomatous ameloblastoma, a thin rim of stellate reticulum like cells, they may be present, that separates these granular cells from the peripheral columnar layer. Now look at this histopathological picture. Here also the presentation is in the form of the follicle. Now look at here, there is a one follicle here which is lined by these tall columnar cells fulfilling the criteria of Vickers and Gorlins. Some amount of here stellate reticulum cells are also there. But in the centrally, these stellate reticulum like cells shows the presence of granular cells. Now at larger magnification you can very well appreciate how are these cells. They are large, polyhedral or oval shape, and see here each of this cell is packed with this eosinophilic granules, and because of this eosinophilic granules you can appreciate the nucleus is pushed to the periphery. The same thing can be appreciated in this histopathological feature. So basically the presentation is that of the follicles or island-like growth lined by tall columnar cells. Then in the centrally stellate reticulum like cells, in the acanthomatous ameloblastoma, squamous differentiation, in granular cells there are presence of squamous cell. Now next variant is the basal cell ameloblastoma. It is, compared to all the histopathological variants, it is considered as a very rarest histologic subtype which occurs primarily in a peripheral location, but sometimes it can be seen intraosseously also. Then how is the pattern? It tends to grow in an island-like pattern. Basaloid appearing cells are there rather than the stellate reticulum like cells. And as they are basaloid cells, the staining characteristics is very deeply basophilic. Now the cells in the central portion of the tumor islands, they may be polyhedral to spindle shape, but stellate reticulum like areas are absent. This point to be noted that up till now we have discussed follicular ameloblastoma, granular cell, acanthomatous. In all the growth pattern, there were presence of the stellate reticulum like cells in the center. Whereas the basal cell variant, here the stellate reticulum like cells are absent. And the peripheral cells, they may be low columnar to cuboidal, and they often do not demonstrate any reverse nuclear polarity or Subnuclear vacuole formation means in these basal cell variants, the criteria for Vickers and Gordon's may not be fulfilled. Then hyperchromatism and palisading of the nuclei, they normally are retained, and this histologic subtype shows a marked resemblance to the basal cell carcinoma. This is very important to remember. Basal cell carcinoma, it is a malignancy seen in the skin. It is also called as a rodent ulcer. So it is very important from prognostic point of view to differentiate the basal cell carcinoma from the basal cell variant of the ameloblastoma. Now look at this histopathological feature. See here, how is the growth pattern? It is typically island-like or the follicular. Here, see here at a larger magnification. Now this follicle is lined. The peripheral cells, they are low cuboidal. At places you can see that they are tall columnar also. But though they are tall columnar, they does not show any palisaded pattern or any tombstone appearance, and they do not fulfill the Vickers and Gordon's criteria. Second, how are these central cells? Here you can appreciate that in other variants, say follicular, acanthomatous and granular cell, we have seen the central cells were that of the polyhedral in shape. Whereas here you can see instead of the polyhedral, you can see oval, or rather you can say polyhedral shapes are there. Polyhedral shaped cells are there, but they are not like that of the stellate reticulum like cells. Now next is the desmoplastic ameloblastoma. Now what do you understand by the word desmoplasia? Yes. What do you mean by desmoplasia? You must have discussed this in the second year when you have studied the general pathology. Yes. Desmoplasia. Desmo is related to the collagen fiber bundles, plasia formation. So when do we refer the term desmoplasia? When there is a excessive collagen fiber formation or excessive collagen fibers, and they arranged in bundles and they give a like a glass-like appearance or hyaline-like material instead of the small collagen fibers or small collagen fibres rather. Then we use the term desmoplasia. Similar type of histopathology is seen in this variants of desmoplastic ameloblastoma, and that's why the name desmoplastic ameloblastoma. So let's see how does it differ from other variants. Now this type of ameloblastoma characteristically is found in a dense collagen stroma that may appear hyalinized. Yes. And second important point to be noted is the hypocellular. Obviously when there is more collagen fiber bundles, then the cellularity will be minimal or hypocellular. Then the desmoplastic ameloblastoma, it has a greater tendency to grow in thin strands and cords of epithelium rather in an island-like pattern. This is again the second differentiating feature. Up till now, the follicular, acanthomatous, granular cell and basal, all four were grown basically in a island-like pattern or a follicular pattern. Whereas, because of this desmoplasia, the islands, ameloblastic islands grow in the thin strands and cords. Epithelial proliferation almost seems to be squeezed out by the dense hyalinized stroma. Then how are the central cells? The central cells are often scant in the epithelial proliferation, and cells making up the periphery of the strands and cords are flattened or cuboidal instead of the tall columnar in appearance. Sometimes this desmoplastic ameloblastoma may show occasional classic islands of follicular ameloblastoma and predominant strands and cords. Now here, look at this histopathological feature. Here you can very well appreciate this marked desmoplasia, isn't it? Now how can we appreciate this marked desmoplasia? See, look at the staining characteristics. It is giving a very intense eosinophilic reaction. And see here, this follicle mostly more or less it resembles to that of the follicular ameloblastoma, hyperchromatic tall cells, peripherally and central, some stellate reticulum like cells. But what happened? Look at here. Because of these desmoplasia, it supports such islands or follicles are there, they are squeezed. Because of them, they are a little bit compressed here, isn't it? So, instead of fulfilling all the classic criteria of the ameloblastoma, here the epithelial islands, you can see, they are squeezed and they are lined in between this desmoplastic stroma, and that's why the name desmoplastic ameloblastoma. Now the next variant, histological variant, is the plexiform ameloblastoma. Now how does it differ? It is distinct from other histologic subtypes in that it lacks many of the core histopathological characteristics that define the other variants. It usually shows a sparse fibrous connective tissue stroma which is often loose and myxoid in appearance. Then, as its name suggests, what do you mean by plexiform? There are thin strands and cords and they appear to connect with each other. So the plexiform ameloblastoma, it shows a predominance of a strand-like growth pattern with a strong tendency to interconnection of the neoplastic epithelium, and that's why the name plexiform ameloblastoma. Then because of these strands and cords, this produce a plexiform network of an inter-anastomosing epithelium, and because of that we call it as a plexiform ameloblastoma. This cellular growth pattern most closely simulates to that of the dental lamina stage of normal odontogenesis before the enamel organ morphodifferentiation and histodifferentiation. We all are aware that before the morphodifferentiation and histodifferentiation in the tooth formation or tooth the odontogenesis begins, the dental lamina mainly shows the interconnected anastomosing islands. Now the proliferating epithelial strands are composed of two layers or bilayer of cuboidal to low columnar cells. In other areas, the lamina-like strands may expand because of the proliferation of the epithelial cells between the bilayers, and these proliferating cells resembles to that of the stellate reticulum-like cells. Now look at this histopathological feature. Here you can very well appreciate that these odontogenic epithelium, they are growing in thin strands and cords. Here, yes, you can appreciate here. Look at here, these thin strands and cords, and they are interconnected with each other. That gives a typical picture of anastomosing strands and cords, and that's why the name plexiform ameloblastoma. Now here in the central portion, here you can see some of these central cells show proliferation and they simulate to that of the stellate reticulum-like cells. So here we had discussed in detail about the clinical features, histopathological features, radiographical features of ameloblastoma. To summarize, clinical features of the ameloblastoma, it is very slow growing, relatively asymptomatic swelling which mostly presents with the asymptomatic swelling, clinically present with the facial deformity. Patient may not aware of the growth of this tumor. Patient will come to you, patient present clinically when there is a facial asymmetry. So that is the first, and without any complaint of pain. So that will be your patient's first clinical presentation. Then radiographically, yes, your patient comes to you with the massive large swelling, then obviously you will go for the radiographic examination. What the radiographic examination reveals? There is a characteristic radiographic presentation, that is a soap bubble appearance. There is a single or maybe the multilocular radiolucency, and it classically presents as a soap bubble or the what you can say the honeycomb like presentation. Sometimes the presentation may be unilocular also. So when it is unilocular in the posterior region of the mandible and seen in relation to the impacted tooth, then it gives the differential diagnosis to that of the dentigerous cyst. You must exclude or you must differentiate it from the dentigerous cyst, because dentigerous cyst, it is a cystic lesion, its prognosis is good as compared to the neoplastic proliferation, that is the ameloblastoma. And then lastly, histopathological features. Histopathological features, though it present with the various patterns like follicular ameloblastoma, plexiform, granular cell, basal cell, then this what you can say desmoplastic ameloblastoma, but to histopathologically to diagnose this as an ameloblastoma, first criteria is that it should fulfill the Vickers and Gorlins criteria, and after the fulfilling the Vickers and Gorlins criteria, there are certain changes in the central cells. So now today we will stop here. Further, after this histopathological features and various histological variants of the ameloblastoma, next lecture we are going to discuss about the what is its treatment modality. Fine. So let's stop here and we'll discuss about the next lecture.